Community-acquired pneumonia general investigations. Investigations are aimed to confirm the diagnosis, assessing disease severity, guiding appropriate treatment, assessing the presence of underlying disease, enabling identification of complications, and monitoring the progress. Oxygenation assessments and patients with an autosaturation of below 92% on admission or with feature of severe pneumonia should have arterial blood gases measured with documentation of inspired oxygen concentration. Chest X-ray should be performed promptly in hospitalized patients with the aim of securing the diagnosis in the time of antibiotics to be administered within 4 hours of hospital presentation. Classically shows consolidation, although other appearances include interstitial infiltrates or cavitation. Chest X-ray appearance is not usually helpful in predicting the causative pathogen, although multilobar involvement or pleural effusion are more common in bacteremic pneumococcal disease, and cavitation may suggest Staphylococcus infection. Computed tomography just may be useful if the diagnosis is in doubt or the patient is severely ill and failing to respond to treatment in order to exclude abscess formation, pleural infection, underlying malignancy, or other underlying lung disease. Blood tests include full blood count, white blood cell count more than 15 multiplied by 10 part by 9 suggests bacterial, particularly pneumococcal infection, and the counts of more than 20 or below 4 indicates severe infection. Deranged renal and liver function tests can be indicative of severe infection or points to presence of underlying disease. Liver function tests may be abnormal, particularly with right lower lobe pneumonia. Raised urea is a marker of more severe pneumonia. Metabolic acidosis is associated with severe illness. C-reactive protein is useful to management or to aid management, with high levels being a more sensitive marker of infection than the white blood cells or temperature. Serial measurements are very useful in assessing response to treatment. Procalcitonin may be useful in predicting bacterial infection and shortening of antibiotic duration, but the evidence of clinical benefit is limited and has no routine rule currently in community acquired pneumonia management. Bronchoscopy may be helpful, especially after intubation on intensive care unit, to suction retained secretions, particularly if they are causing lobar collapse, to obtain further samples for cultures and to exclude an endobronchial abnormality.